this week on the BackTable podcast.
Yeah. I think, always kind of go back to like first principles, right? So think about why we use certain embolics in certain areas. Think about like all the downsides of that maybe you haven't rethought of, right? Like in years of practice, right? Like a lot of us have kind of just accepted certain things and we know how to handle it, right? But if you kind of go back and start thinking about that, I think you start finding these kind of use cases where you're like, oh, hey, maybe I should do this instead here. And I'm no longer facing some of these downside issues. And when you start doing things at volume, that does add up, right? Because you do have issues like 1 out of 50 to 100 times. And, if you can kind of start chipping away at that, mitigate some of those problems, you make your life a lot easier and your practice a lot stronger. So keep an open mind.
I'm your host, Dr. Ali Baheti. I'm coming to you from Tacoma, Washington. I have on the show today a special guest, Dr. Keerthi Prasad. He's an interventional radiologist at Centers for Pain Control and Vein Care in Indiana. Dr. Prasad, thank you for coming on the show.
Hey, thanks for having me, Ali. Really, really appreciate the chance.
And you're not new to the show. I know you've been on the show before. I think Shamit interviewed you for something about OBLs a little while back. So thanks for coming back, I guess I should say. Can you tell us a little bit about your practice first, kind of what the makeup is?
Sure. Yeah. So it's actually changed since we last spoke. I think a few years ago, I was just running a full-time OBL and a few ASCs. And since then, we've kind of shifted. I now run a company called Embolic. We're a national company that builds OBL partnerships in the MSK space. So we're in like 20 different states and really just growing IR practices, kind of where the patients are and keeping IR ownership in that production model. So a lot of this is outpatient embolization, as you might imagine, and GAE and other MSK procedures are really a big source of growth.
Wow, that's really neat. I had no idea that you totally switched your practice up. Kind of what brought about that change?
Yeah, that's a good question. I should think harder about that. But it's my background is running OBLs within pain practices. That was my first gig out of fellowship. I kind of grew my own practice that way. We brought on a bunch of people, and I kind of saw the power and the value of that collaboration. You do one of two things, like, pain docs are really good at making efficient outpatient procedures. I feel like in interventional radiology, we've been kind of slow to do that. We kind of stay at this high-end model, which it makes it really difficult to bring those procedures to the broad populace. I think you can learn a lot and you go where the patients are, you learn to do these in a lower acuity setting, and you make them more accessible, right? And we get incredible results from patients all the time. And I know if this was purely like, hey, I'm going to hang out in the hospital, try to build a hospital-based practice, like we'd never touch any of these patients, right? And these people would just be in pain. So this is really, for me, this is the way to do it. I know everyone's got their own kind of model, but this has been great for us.
That's super fantastic. So it's like is it an MSO or is it like ownership and then you hire IRs in different areas or what?
Yeah, it's a good question. Kind of a hybrid model in different areas. I think it's most akin to the MSO model. We do bring in local IRs and we kind of train them up in our kind of outpatient technique. Mostly experienced people, but people who want some part-time work, maybe a break from what they're doing typically. Some people are doing teleradiology other times. But for us, really, it's just it's to grow the practice and grow the volumes, but also keep the IR ownership and the IR involvement there. I think it's like a slippery slope where you just kind of turn it to like a hired gun model, and that's really not what we want. There's a lot of expertise that we have. It's really just about bringing it to the outpatient environment. So, we're in like 34 facilities today. None of those facilities could run without our IRs doing this and the clinical involvement every day. Yeah.
That I am super excited to see that grow and having a model where the IRs have ownership in the facility is just really going to be key to the specialty in the future as well. So thank you for doing that.
Yeah, thanks.
Thank you. On behalf of all IRs, thank you. All right. So what we're really here to talk about today is resorbable embolics, specifically in the joint embolization procedures and other outpatient embolization procedures. So just for the basic kind of like layperson who's just getting started with MSK embolization, what resorbable embolics are available in the U.S. market today?
Yeah, sure. So I don't know how many lay IRs there are.
But, for your common man, your common Joe IR, I guess.
Yeah. So that's an interesting question. When you look at the original data behind GAE, a lot of it is with Imipenem, right? And that's kind of the international experience. That's available. It's cheap. I don't think most US IRs have a lot of experience with it, but I'll tell you, it's actually very easy to use. And you can really get it through almost any like national distributor, right? Like Medline, Henry Schein, they'll all sell it to you. It's a little unusual, I think, for us in the sense that like no one really knows a lot about it. And if you told another physician, they'd be like, wait, well, you're doing what? As far as that, is concerned, like I think that's it's well known, like that it works in GAE, and we can talk about that a little bit. Kind of more like frontier kind of embolics that you might be able to get in the US. Lipiodol, right? That's something I think we all have a lot of experience with. Not a lot of people using it in this way, probably for a few different reasons. But that's another one. And then, there is a product called Ecobi. It's from a company called IM Biotechnologies. We have a fair amount of experience with that as well. It's resorbable, but not like, it's not a short-term resorbable, right? Like a lot of the newer interest, I think, is in things that resorb within days. Ecobi takes a few months. So, I'm not sure if the benefit is necessarily the same, but that's one that's like broadly available. It's a Canadian company. It's a small company, but again, like you can get this, anywhere. You can use it. You just have to order it. I think that the new one that I don't know if it's available outside of trials, but is Nexsphere, right? That's, if you look at, if you talk to Dr. Okuno in Japan, he uses a lot of this. It's a Korean company. I think he out of Japan worked with them closely in the development of Nexsphere-F, which is like the quick reabsorbing embolic. That's very interesting. That's an interesting product.
What makes Nexsphere like different from the ones that currently exist?
Yeah, so I think it's a couple of things. Like one, the particle size, right? So it's 100 to 300 microns, which is kind of that sweet spot for MSK embolization. Probably on this, our practice is kind of on the lower end of that. We try to really go around 100 microns, but it's a good size. They're calibrated. It's very predictable, right? As a result of that. And then as far as the rapid absorbable component, I think it's within like 1 to 2 days that it tends to resorb. So that recanalization effect happens very quickly. And that's a little unique. I think so. You've done two things. Like one, Imipenem reabsorbs in the same amount of time, but the particles are much smaller, right? And that's kind of a negative for us. I think your average like Imipenem suspension is probably around like 20 to 30 microns, right? It's very small. So you've kind of, and that's not really desirable. So you've kind of solved that problem. You've brought it kind of in line with the microspheres that everybody uses, but you've also made it resorbable in a similar time frame. I'm pretty sure, like, this was a very targeted product. They knew what they were doing when they put it together. Yeah.
Okay. So I think I kind of understand the difference between the 4 possible resorbable embolics. Yeah, 4 plus.
Okay.
What are the differences in embolization endpoints when you're using resorbable embolics versus kind of what we're used to, which is permanent embolics?
I think when you do this at scale, you realize a couple of things. Like one, like most of the time you can get where you need to be. There's a fair amount of times where you can't, right? Like you're close enough, but there's going to be some non-target.
In terms of getting your microcatheter out distal enough.
Yeah, that's what I meant. So from a technical perspective, there's going to be cases where they're just branches going to the skin, right? That you just can't avoid. People try to use ice packs, sometimes manual compression to try to divert some of that flow. But with the permanent embolic, you're going to be a little bit more cautious, right? With the resorbable embolic, I think you can probably be a little more laissez-faire, and not to say that anyone practices that way, but I think your threshold kind of goes down. And then with like Lipiodol in particular, if you look at the techniques, you're just kind of injecting it into the genicular. You don't really even have to get very distal, and they have great results, right? So I think you do two things. Like one, you decrease the stress for the IR, and then two, you also kind of turn it into like a lower skill procedure. I don't want to say like anyone can do it, but you make it a lot easier, a lot faster,
safer. Yeah,
safer, right? Yeah. So your endpoint, it's not like, it's a much more I think subjective endpoint here. We're not looking for like beats of stasis or anything like that. It's more like, hey, I kind of saw a blush. I've eliminated that. Let me see what's left, right? But if you're using a liquid like Lipiodol, let me just fill it up and move on to the next vessel, right? It's a lot simpler.
I see. Okay. And then you mentioned, specifically talking about Imipenem, which is the most available in the US. As somebody who's never used Imipenem before, I'm like, oh man, I'm sure there's tons of differences in how I use this compared to how I use Embospheres. Can you kind of give me a tutorial for a beginning user who's just starting out with Imipenem?
Yeah, sure. So it's available as a powder, so it needs to be reconstituted. That it's kind of a 7-to-1 that would generally do with contrast. But I'd recommend you kind of experiment and see what you're comfortable with, because everyone has some preference on that, right? It tends to suspend reasonably well. Usually, we just there's different ways to do it. You can either do it on the field, or you can, inject contrast into the vial, mix it up, and then pour it into the field. There's different ways of doing that, but it suspends reasonably well. It's great for like the kind of blush that you can't even necessarily see the microvasculature, right? The neovascularization, where you just want to eliminate that. It's really effective in that. I would caution you from trying to take care of like larger fields with that, though. You're not going to get like to that endpoint very quickly with Imipenem. That's our experience. For people who haven't done a lot of GAE, if you're doing this in a post-total knee patient, they have a lot of synovial hypertrophy, and those vessels tend to be very large. You're not going to get very far with Imipenem in those cases. It would just take too much volume and too much time, and it's probably not the right product for that case. So I think two things. Keep in mind that it's very small particles. So, the volume you would use is probably ends up being a lot higher than you would otherwise. You're mostly injecting contrast when you're doing this. Number two, like pick the right size particle for the right size vessel, right? Those are the two things.
To like get into that for a little bit, like kind of when you do GAEs with embospheres, for example, you almost never put more than half a cc in each vessel, right? Is it the same with Imipenem, or do you end up putting in quite a bit more?
For the use case, I would say it's slightly more than that, but a lot of times we'll actually back it up with some beads if we need to.
Okay.
Yeah. So I think that's kind of my thought process. Like if we've eliminated the real downstream vessels, let's back it up with 0.1 mLs of some Embosphere or Embozine, right? And then just kind of like seal the deal there.
Oh, interesting. Okay, so it's kind of like it's a layer cake. Interesting.
Kind of, yeah.
That you got to do. Okay, yeah. And sorry, I cut you off there. You were telling me one more point about Imipenem.
Yeah. So the other, I think, use case is when you're really, you're kind of in a spot where you're getting some non-target, you don't know what to do. Maybe that's the time to try it. If you're convinced you have to do something, I would use it there. Yeah.
Would you say that your practice, the practices that you work with, are exclusively using resorbables now for genicular embos?
No, by and large, it's still Embozine or Embosphere, just standard particles. And that's mostly due to availability. And I think the data, we still have a lot more data with those products. But, as that changes, I think everyone knows that we'll be using resorbables at some point. We're just not quite there yet.
Yeah. And the major limitation, it sounds like, is just that the existing resorbables that we have in the U.S. are either too small or not well calibrated.
Yeah, I think that's it.
Really?
Yeah, I think so. And I think there's just a general comfort level with like a calibrated product, right? Like everyone knows what they're getting. You know what you're doing. It's kind of like if you use a gel foam slurry, like your gel foam is different than my gel foam, right?
Yeah.
It makes it hard to standardize. Yeah.
Sure. Okay, so I think we talked about Imipenem a fair amount. Any other like tips and tricks for folks that are first starting to use it that you've seen people get into trouble with?
No real areas of trouble. I think the hardest part about it is actually getting the product. I think people think that like you can't get it or it's challenging to, but you just order it.
Order it. Yeah.
Yeah.
Yeah, I know. That is a really good point. We're so used to, especially with newer products, right? We're like, oh man, it's so hard to get. We have to special order it from here or there. And you're like, no, like you just order it from the pharmacy or from Medline. Yeah, it's kind of amazing.
Yeah, they'll give it to you.
One last thing about Imipenem, a lot of people worry about antibiotic resistance, right? When you're using that. Just anecdotally, have you seen this be an issue in patients that you've treated?
No, luckily we have not. It'd probably be challenging to actually see those data points, right? Because we just see these patients a couple times as outpatients. They go on with their lives, right? And I think two things there. Like one, the vast majority of people with knee pain are like otherwise healthy individuals, right? So it's not like the normal like hospital IR population where these people have PICC lines and PICCs and they've been on antibiotics for their whole lives, right? Like it's just very different, So I think one, it's unlikely, and two, Imipenem's been used for decades at this point, like in Asia as an embolic, right? And that's never really been a broadly reported concern. So I think maybe at face value, like that's something that pops in our mind because anytime you use an antibiotic, you want to be conservative, right? But it seems to work just fine without those issues. So I think everyone should be comfortable.
More of a theoretical than an actual risk. Okay, got it.
Yeah. And I think it's a natural theoretical risk because that's where our minds go immediately, right?
Yeah. All right. Now, when you talk about resorbable embolics, how can you explain that the long-term outcomes are still very good when the product is gone from the patient's system, either almost immediately or within a couple months?
Yeah, I think that's an excellent question. I kind of fall back on some of Gervais' data with Lipiodol, and I don't think this is representative of the whole board, but what you see is, the Lipiodol clears very quickly, right? But it seems to particularly impact the neovascularization versus normal vessels. Like those tend to not recanalize. And I think it's probably for like two reasons. Like one, it's just the size of the vessels, right? Like we know that like bigger vessels tend to just recanalize more effectively than tiny ones, right? That just makes sense. And then number two, I think those are already somewhat inflamed vessels, right? So there's some kind of inflammatory component there promoting that thrombosis and occlusion of those vessels. So I think it's probably related to that. And larger vessels, they just recanalize on their own. Smaller ones don't, right? So I think we're just kind of taking advantage of just normal physiology. Gervais demonstrated that with Lipiodol, which is very interesting because I wouldn't have expected that because Lipiodol clears very quickly, right? Like, why would that work? But it seems to do it. So, it's kind of interesting. And, it also brings to question, like, the necessity for a permanent embolic, right? You'd actually say like, well, in this case, you don't actually need a permanent embolic. You actually need something temporary, right? That's what you need. So that's maybe where we should be looking.
Do you have discussions with patients or referrers about kind of the long-term durability of temporary embolics versus permanent? And then I guess the corollary to that question is like, what do you give as your expected outcomes after like a GAE, for example, for how long it'll last? I get this question a lot. Yeah.
Everyone asks that, right? I think those are two really good questions. Regarding resorbables with the patient discussion, it's actually very interesting because I hear the alternate question a lot from patients like, hey, how long do these beads stay in me? Because people don't like the idea of foreign bodies staying in them. Even when you say like, hey, it's 100 microns, it's imperceptible.
Yeah.
You'll never notice it, The patient acceptance of a resorbable is much higher, in my opinion. Not that, the resorbable or the non-resorbable or the permanent is like a deal breaker, but I think it makes people more comfortable for sure. I don't think our referring docs really care, to be honest with you. They're just like, hey, it works. Okay, that's awesome. But those patient discussions are very interesting because people are very cognizant of like a lot of these aspects and some things that we kind of take for granted, right? As far as, how long does it last, right? That's a very interesting question. So we deal a lot with the chronic pain population. So I think the standard pain endpoints are like a couple of months, maybe a year. And I feel like GAE definitely beats those. So it actually works in our favor when we're having those discussions with patients. When you look at the data as a whole, most of it goes out like 1-2 years, right? So we say, hey, about 70 to 80% of people, they report their pain being cut in half at the 1-year mark. So for us, that's something that's durable. And I feel like it's going to last, right? Like if something lasts like 2 or 3 months, like it's probably going to come back like in everybody,
Sure.
right? Like why would you do it, But once you get out to that 1-year mark, you think like, okay, this is something that's probably going to last for a while, right? And then, everybody's still using their knees, right? So that process is still happening, that the development of that neovascularization, that inflammation, that kind of cycle that we're well aware of. So they should expect it to come back. But, it probably took them decades to get to that point too. So we see some kind of repeat patients, but a very small percentage, at the 1-year mark. Yeah.
Interesting. Okay. Yeah. And I think, are you more likely to retreat a patient if, for example, if you'd used a temporary embolic early on, or is there no real difference?
Actually, we don't look at the embolic that we use. Rather, what was the patient's response? So I think there's two categories. Like one, hey, doc had a great response. It's come back. So that tells me one of two things. Like one, maybe they were under embolized, right? Maybe, we try to do 2 or 3 vessels, right? If someone has based on laterality. Maybe, only one or two were treated, right? And then they've kind of redeveloped some collaterals or, neovascularization from the remaining vessels. Like they're under-embolized or like, hey, it's kind of just gone its course and it's come back, right? Like it was pretty decent embolization, but it's been 1-2 years, it's starting to come back. And in those cases, the kind of repeat procedure, the imaging tends to demonstrate like what we suspected. That's usually what the case was when we compared to the original images. I don't think that, resorbable or permanent makes a big
Doesn't
difference
make a difference.
there. I don't think so. The other group of patients you'll tend to retreat, I think, are ones that maybe reported medial pain, and then they come back and like, hey, the lateral aspect of my knee is bothering me now. And you're like, okay, well, we'll do it, But it's actually an interesting question because patients who tend to be tender on both ends, both aspects of their knee, like medial and lateral, which I don't think is the majority. I think we're more comfortable using some resorbable embolic there because the total volumes are lower. You may need to treat 4 or 5 vessels in those cases. And obviously we leave the normal genicular intact, right? But you get to higher volumes, so it's kind of nice to be able to use some resorbable, some imipenem, and then back it up with some beads.
The beads backup is cool. I think I might steal that. That's pretty neat.
Yeah, you should try it.
Kind of like at the end. Yeah.
yeah. Let me know what you think. Yeah.
We kind of touched a little bit about like side effect profiles with definitely like we talked about with Imipenem. Any other things that are worth mentioning in terms of like side effects as it relates to permanent versus temporary embolics?
Yeah. So like side effects for GAE, I think that like skin petechial appearance, I mean, it's a side effect, but it's also an expected outcome. Like almost like half of the patients get some of that. And I think you just tell them like, it's going to go away. Your knee's going to get better before that goes away, but it's of no consequence, right? I think occasionally we hear reports of like skin ulceration and things like that, but it's exceedingly rare. You can definitely avoid some of that, right? With using a resorbable. I think that's the biggest benefit of it, right? Like some of those collaterals, they'll just recanalize within a day or so and the vessel's fine. Some of the more serious complications you might hear about are maybe like distal injury, right? Some of the kind of foot drop, nerve issues, or even, I mean, if you got really aggressive, maybe, I don't know, you send something down the foot, which I've never heard of, but, potentially could happen, right? And then when you talk about some of the new frontier kind of indications for MSK embolization, right? Like plantar fascia, things like that. I think within resorbable, people will get much more comfortable doing it, right? Like we're usually doing the opposite. We do not want to like embolize things down there. And all of a sudden we're telling people to do that. And then when you think about like some of the maybe simpler techniques going forward, right? Like I think this is more common in Asia, but people will just do like a distal access into like the posterior tibial or the lateral plantar, and then just do kind of a non-selective injection of a resorbable embolic. And, that's a much lower skill procedure in my mind, right? Like, I don't even know if you need an interventional radiologist to do that. I mean, I hope you do, but, like maybe you don't. But all of a sudden, if that's something that works and you create a product that allows that to happen, I think that's great for people, right? Like you've made a really easy procedure widely available to people.
Yeah, I know, right? It's kind of like with some of these MSK procedures, you're like, oh, this is like pretty simple. I can see how this can get commoditized or, taught to other practitioners pretty easily. It's a tightrope, right? Because you're like, oh, I like this. I want to keep doing this. But also there's like this gigantic population of people in the US that need to have this done. Definitely not enough IRs to do it. And it's going to be interesting over the next few years to see how this expands.
Yeah. I think that's kind of a constant battle in our fields.
Oh, yeah.
We'll see. Yeah, we'll
saying,
see.
Inventing procedures for other specialties since 1955 or whatever.
Yeah,
it is.
Yeah, exactly.
Okay, well, we really have mostly focused on like knees just because I think that's the path of least resistance into MSK embolization. And Jacob would probably be a much better interviewer for this part. But what do you think about resorbable embolics in other parts of the body? Like we talked about shoulders, plantar fasciitis, anything I'm missing?
Yeah, I think the elbow, right? So like people report golfers' elbow, that epicondylitis, right? I think the resorbables are probably going to make a bigger difference there than anywhere else. That's a tough spot, I think, for most people to comfortably embolize. Maybe you go radial, you do it, but kind of mixed data. And I think there's a lot of anatomy we're not as comfortable with, right? Like most of us are pretty comfortable with leg arteries, but Arm, maybe not so much, right?
Sure.
Yeah, so like there and the plantar fascia. And I think really if you can, the future in these is really getting them to that commoditized kind of point that you described. I don't think that puts us out of the game, right? There's going to be challenging cases and someone has to run the service and someone has to understand everything that we're talking about, right? But, if you want to treat everyone with plantar fasciitis, like it can't be an interventional radiologist doing it, I think. Like at some point it'll be somebody else. But yeah, that's probably the future for a lot of these things. Shoulder, I actually think the permanent embolics work really well. Obviously, that's just for adhesive capsulitis. I'm not really doing any other indications. I've heard of people doing a couple different things, but it seems like it works really well there. Again, like non-target issues, you just need really good imaging, right? As long as you have solid imaging, I think you're okay there. But yeah, I think it's really going to be knees, plantar fascia, elbows, that's a lot of work for all of us. So I think it'll be good. Yeah.
Turns out everybody has two of those usually, unless
Yeah,
they've
right,
gotten an AKA, right? Yeah.
Yeah, that's true. It'll keep us in business.
Kind of talked about this already, but like, what do you see as the kind of the future for things like Nexsphere or any other temporary embolics? Do you think there's going to be a boom where a bunch of these come to market at once?
Yeah, it's actually interesting because even the permanent embolics, like it's not on label yet, right? We've seen a lot of these devices kind of get investigational device exemptions, right? And like we've seen a lot of enthusiasm behind that, but I do think it'd be great if it was on label, right? Because at the end of the day, there aren't a lot of us to get the word out, right? Like interventional radiologists. But the minute the industry gets behind this and they can market it, I mean, we all know what happens, right? They're going to be growing the market for us and with us, hopefully with us, If you have a kind of novel device like Nexsphere, maybe that has a better shot of kind of doing that in a clean fashion. But I hope that like your Embozines and Embospheres kind of get an on-label approval soon, because then we'll have the industry behind us. We'll be able to get the word out. We'll be able to really, I think that'll lower the barrier to entry with discussions with other specialties, like let's really get this kind of in the guidelines. And, I'd also tell people like, what's the standard of care for knee pain? It's kind of all over the place. So that still needs to be defined, right? And we have an opportunity here to do that.
Are there any novel uses or novel embolization procedures that y'all have pioneered that you think might come to the Gen Pop soon?
Yeah, sure. So I don't know if we pioneered it. We probably heard about it from someone.
From Acuna that Acuna pioneered. And
yeah. I probably stole this one from him, or maybe my buddy Oz, right? Probably took it from him. Yeah, we've been doing lateral circumflex embos for hip bursitis, or greater trochanteric pain syndrome, which is, I guess, the new name for this.
Okay.
Yeah, and it's great because it's a procedure that has it's all greenfield. Like there's no good treatment for those patients. It's really like NSAIDs and PT. The PT helps, but it's very challenging. It takes a long time. And if you have this problem, you can't sleep. Like it's hard to use stairs. Like, I mean, it's very, very debilitating, right? And it's fairly common. And steroid injections worsen it over time. So you might be okay getting like one steroid injection, but once you get to like 3, 4, the outcomes actually get pretty bad. So you really don't want to be doing a lot of those. So, and it's a pretty easy procedure to do. It's right off the profunda and kind of go in there. I think you see a little bit more non-target than you would around the knee. So it's a great spot for the resorbables. The Imipenem, I think, is nice. It's very interesting because similar to the knee, a lot of times when you do a run or a contrast injection, it recreates the patient's pain. And so you kind of know you're in the right spot, So yeah, we see that a lot with the geniculars too, but maybe I inject kind of hard. I don't know, but it's helpful in this case.
I guess that's a good question, because people ask me too. They're like, well, sometimes I'm injecting and I don't see the blush, but it's like going to the area where the patients have pain. Should I still be embolizing that artery? Yeah, and maybe it's just like not hard enough of an injection, because if you're recreating the patient's pain with your hefty injection, then you can make blush,
yeah, exactly. You create it. And I mean, for us, like, I wish this was something we could track better, but anecdotally, it seems like that's pretty well tied to kind of outcomes. I've had a minority of patients where they get better on the table, right? Like you do this and I can't explain it, but they're like, oh, it doesn't hurt anymore. I'm like, injecting as hard as you can, and nothing happens. And like, okay, that's cool. I don't know why, but occasionally that'll happen. Yeah.
Wow. Yeah.
So yeah, hip bursas, good procedure.
Do you still do those from pedal, or do you go up and over?
Yeah, it's a lot easier up and over. We do a lot pedal though, and that's just like some bias for
Sure.
It's pretty easy, actually, to be honest with you. Your equipment costs are probably higher than if you went up and over. But for us, a lot of it is tied to like how our procedure rooms are structured. We're really kind of tied into that pedal approach. And, it's also like less invasive feeling for the patients, like they don't have to, they just show up in shorts or whatever and just going through their foot. It's kind of nice. They like it. Yeah.
Well, you mentioned earlier in our talk, kind of IRs are not used to efficiency being like a primary goal, right?
Yeah.
And kind of what you're talking about, like kind of doing everything from one approach, really helps streamline your turnaround time for rooms. They don't have to move the C-arm around, switch the table around. Techs and nurses don't get confused. And yeah, and you're right. I mean, just kind of like keep it as simple as possible for everybody. Yeah. That's one of the tenets of outpatient work for sure.
Yeah, 100%. Like everything's faster, everything's simpler. It's a lot less training for everybody. Everyone's more comfortable. You're never going to have a groin complication if you want pedal, right? Like all these things are kind of nice. No sedation, right? Because you don't need to sedate someone for a pedal stick, but maybe a groin stick you do,
Oh, wow. I didn't realize you were doing all of these no sedation. That's really cool.
Yeah. No, we never sedate. Yeah. It's an added complication, right? Added complexity, got to keep it simple.
One thing I've found when doing a pedal approach for geniculars, at least, is like I feel like a lot of the angles are better when I go antegrade. I mean, you probably have streamlined the catheters, the specific catheters and microcatheters you need to get into those, especially like superior medial and superior lateral and descending.
Yeah, I think it's easier from above, right? Like, it's just from above, they kind of just fall in sometimes. It's definitely easier from above. I think you need some kind of reverse curve catheter in a lot of cases, like whatever you're comfortable with. For some of those, like kind of steep superior vessels, I think most of your descending geniculars you can get into with almost anything. Honestly, like when we first started, I just used an angle glide cath and we could do like 90% of our cases, but we've kind of gotten a little bit better now. We're using more reverse curve catheters. I think when you do enough of these, you can actually do most of the case just with a micropuncture and a microcatheter. We do a lot of that, but your image quality is going to be suboptimal, right? Like from the SFA or whatever. So you should really only do that once you've like gotten very comfortable with the anatomy, I think. Yeah.
Very cool. Yeah, I think it's going to be a interesting discussion we'll have over the next 5 years to see how this, I mean, it's just blown up so much even over the past 5 years since you and I first started talking, I think. Like this wasn't a thing really. I mean, it was, but like people weren't really doing it. And then I'm really interested to see how this grows and changes and gets better over the next 5 years. It's going to be something.
Yeah, likewise. Very exciting.
Cool. Going back to kind of your pain practices that you've developed, I'm sure you offer other things like genicular nerve ablations or steroid injections and everything. So what's your approach for when you see a patient with knee arthritis? Like how do you work them up and how do you decide what's the right procedure for them when you have like pretty much everything on the menu?
Yeah, that's a good question. So take a step back. What's the natural history for most knee pain? It's that it goes away. That's like the first thing you should always keep in mind. So if someone's only had knee pain for a couple months, like just stay active, take some NSAIDs, it's probably just going to get better. And everybody will get knee pain at some point in their lives, right? So it's not abnormal. That's just a normal thing. Now, most of the patients we see in the pain practices, they have chronic pain, right? Like it's been going on for a while. It's important, I think, to go from a path of like least invasive to like slightly more invasive to invasive, right? So, NSAIDs, activity, maybe some PT, that kind of thing for the right patients. I think that's great. That's like what everybody should do. I don't know if everyone will go to PT for their knee pain, but we recommend it, I think the next step from there is just like an injection, right? Like intra-articular injections are very easy. I wouldn't recommend too many steroid injections, but patients feel great. They feel amazing after you get a steroid injection, and it works really well, right? Like, because it still stands by that principle where like most of this will get better, right? You kind of help with some of the inflammation, you bring that down, they still take some NSAIDs, they're able to stay active, use their knee, it's going to feel better, right? I'd say a lot of our practices, they also do visco supplementation. So like hyaluronic acid injections, they, depending on the product, they happen at different frequencies and different durations. The data there is like a little mixed, right? Like when you look at it, it's actually not like, it's not as good as like a steroid injection. It's not as good as GAE actually. But the truth is it's very easy to do and it costs a lot less money than like a GAE. So you come in like twice, maybe 3 times, sometimes just once, and it's just an injection, right? And it's a lower bar for the patients too, right? Just injecting something and so on, they don't think it's a big deal. They want to try it. So we'll generally do that. The practices that don't do that, it's usually like some regional variation on kind of the payers. They don't really cover it all the time, or they only cover certain products, and it's a little confusing. And then once people have kind of failed those things, that's when we start having that GAE discussion. And, we do all of ours pedal. So I tell patients like, hey, there's no incisions, nothing like that. It's a lot like an IV going into your hand or wrist, but it goes into an artery in your foot, right? Like that's something relatable to the patients. And it's really patients who have failed those other things. So for me, failure of those things means like you've tried them a fair amount of times and like you've gotten no response, or maybe it benefited you before and no longer does, right? So it's a small percentage of people. Like we're talking in the low single digits. Like most people, they're screened out by the time you hit this point. And then, if they don't want GAE or GAE doesn't work, that's when we start talking about genicular RFs and then maybe peripheral nerve stimulators in some patients where it's very severe and like refractory to everything. Yeah. Which are actually very easy to do. Like I think any IR can do a PNS implant and trial, and they're maybe not that common, but very, very easy procedure to do.
Yeah, they really are. I just started doing them like
you're doing
the
them?
past couple of months. Yeah. And
great. Yeah. So in my experience though, like I feel like sometimes they work great, sometimes, maybe not as great. Yeah.
Yeah. And there's like I don't run a pain practice. So I feel like once you start offering that, you end up getting a lot of pain patients,
Yeah.
And you're like, this is not what I was going for.
Yeah, that's another beast.
Right.
Yeah.
Anything else that you think our audience should know if they were just starting to use resorbable embolics for the first time, or just kind of want to incorporate it into their existing practice?
Yeah. I think, always kind of go back to like first principles, right? So think about why we use certain embolics in certain areas. Think about like all the downsides of that maybe you haven't rethought of, right? Like in years of practice, right? Like a lot of us have kind of just accepted certain things and we know how to handle it, right? But if you kind of go back and start thinking about that, I think you start finding these kind of use cases where you're like, oh, hey, maybe I should do this instead here. And I'm no longer facing some of these downside issues. And when you start doing things at volume, that does add up, right? Because you do have issues like 1 out of 50 to 100 times. And, if you can kind of start chipping away at that, mitigate some of those problems, you make your life a lot easier and your practice a lot stronger. So keep an open mind.
Keep it good. Excellent words of wisdom. Keep an open mind. Never fails. Well, Dr. Prasad, thank you so much for coming on the show. We really appreciate your expertise, and best of luck with growing this venture. Sounds amazing.
Oh, thanks, Ellie. Appreciate it. I like listening to the podcast. It's great.
Thank you so much for listening. If you haven't already, be sure to follow, rate the show 5 stars, and share with a friend. If you have any questions or comments, direct message us at @_BackTable MSK on Instagram, X, or LinkedIn. BackTable MSK is hosted by Jacob Fleming,
Michael Barraza,
and Chris Beck.
Our audio team is led by Kieran Gannon, with support from
Aaron Bowles, Josh McWhirter,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and show notes written by Marvi Espiritu
and Ann Dang.
Administrative support provided by Judy Dela Cruz.
Thanks again, and see you next time.